So our next speaker is new to KU from about the past year and a half ago, I guess. Dr. Kristy Brown, who's an associate professor of metabolism and cancer in the Department of Cell Biology and Physiology at the University of Kansas Medical Center. We wanted to switch up a little to additional hot topics in breast cancer. And so Dr. Brown is going to talk to us today about an overview of metabolic syndrome and obesity in breast cancer, key signaling pathways, and the impact of sensitivity to therapy. So Dr. Brown, thank you for joining us.
Thank you very much, and thanks for the invitation to both Dr. Klemp and Dr. Sharma. My disclosure today is that I do not have an MD after my name, so these slides will look probably a little bit different to what you're used to seeing at these meetings, but I hope that you'll be able to enjoy them and learn something from them as well. So there's been a lot going on in this space for the last, decade or so, especially with the acknowledgement that obesity is associated with an increased risk in cancer. Today I picked a few studies that I thought were representative of some of the advances that we've made over the last year in trying to pursue a better understanding of this relationship. So obesity not only affects the risk of developing cancer, but it also affects our ability to detect and diagnose cancers. It affects our ability to treat cancers and will also impact survivorship. And I'm not going to go through it today, but we also know that many therapeutics will also influence the risk of developing obesity and impact metabolic health, as we've heard in the previous talk with regards to effects on lipid profiles, for example. So there's now strong epidemiological evidence linking obesity to the development of at least 13 different types of cancer. And the strongest evidence in terms of breast cancer is for hormone receptor positive breast cancer after menopause. Now, you'll see during my talk that the more or the better we understand specific populations or specific tumor types, the impact of obesity on cancers will really expand to additional situations. It's important to note that a lot of these studies were also done in large cohorts where there was very little diversity. So as we better understand how racial and ethnic components influence cancer risk and progression, I think this will also become clearer. And despite all of this knowledge, 35% of breast cancer survivors or cancer survivors have obesity, and less than 17% meet physical activity guidelines. And within that, only 10% eat the recommended amounts of fruits and vegetables. So there's still a lot we can do to improve outcomes for individuals with cancer. So when we think about obesity, it's really defined as having a body mass index of 30 and above. So that's someone's weight divided by their height squared. And as you can imagine, that doesn't necessarily tell us much about their levels of adiposity, so how much fat they have, and their metabolic health. So as we start understanding the impact of metabolic health better in the context of obesity, we're able to better appreciate the impact of these factors on cancer risk and progression. So these images really highlight, that potentially at the same BMI, individuals may have different body composition, and we'll get into, the impact of where that adipose tissue is located later. But in a study that was published in 2024, this was really highlighted when the investigators looked at excess body weight being attributable to cancer risk being 23% when assessed as a BMI value of greater or equal to 30, but at 38% when assessed at percentage adiposity, using a new metric for assessing body adiposity here. So what this does is it really tells us that the amount of adiposity really extends beyond that obesity category of BMI. And this next study really builds on some prior studies that have looked at the impact of excess adiposity in individuals that are considered to have a healthy body weight. So with a BMI that is less than 25, these individuals would not normally be targeted or identified as requiring additional metabolic screens. But we know that some of these individuals have excess body weight attributable to excess body fat. In their meta-analysis, for every 5-unit increment in percentage body fat, there was a 15% elevated risk of postmenopausal breast cancer, and that's within the normal or healthy BMI category. So I think as we better understand this, we'll be able to define additional ways of identifying individuals that are at higher risk. But adiposity is not the whole story. We're finding out that metabolic health is probably a better predictor of risk and outcomes in breast cancer patients. And I mentioned before, where the fat is located matters. Central adiposity is associated with metabolic defects that are associated with higher risk of cancer. Dyslipidemia, insulin resistance, and prediabetes, as well as hypertension, all contribute to the metabolic syndrome. And when we start looking at the impact of metabolic syndrome on cancer risk, in this study looking at data from the Women's Health Initiative, we see that independent of BMI, having a higher metabolic syndrome score is significantly associated with worse prognosis, ER positive, PR negative cancers, as well as a 44% higher breast cancer associated mortality. So this is really even taking away that obesity question and thinking more about this in the context of metabolic health. So when we think about, adipose tissue and obesity influencing cancer risk, it's not necessarily surprising given that the mammary gland or the breast gland, which is the site of origin of cancer, is really embedded in fatty tissue. And we know that this fatty tissue actually changes with obesity and poor metabolic health in a way that we also see in other adipose depots. So we get expansion or increased size of the adipocytes or the fat cells. They produce different adipokines like leptin, which has been associated with increased proliferation of cancer cells, but increased invasion and poorer prognosis. And when these fat cells become dysfunctional and die, they cause the recruitment of immune cells like macrophages, creating these inflammatory foci within the breast, which also can contribute to the development of cancer. In addition to that, cancers can stimulate lipolysis, so the release of free fatty acids within the breast, and this could be used up by cancer cells, both as building blocks for new cancer cells, but also as a source of energy. And one of the areas that we've been especially interested in, which is relevant, especially in the postmenopausal case, is the production of estrogen within this tissue. So this was a study that was presented at San Antonio from Massimo Cristofanelli's group at Weill Cornell, really extending what we know about the tumor microenvironment, and this in the context of inflammatory breast cancer. If you'll remember, this was not something we were talking about when we were looking at, what obesity, what type of cancer was influenced by obesity. But this study used preclinical model systems as well as clinical samples to elucidate the role of a protein called MARX, which is involved in stimulating inflammation within the breast. What they found was that in IBC, in inflammatory breast cancer samples only, the presence of M2 macrophages was associated with obesity, and that obese patients presented with these macrophages had poorer 5-year overall survival. It also showed that MARX was responsible for stimulating the infiltration of these macrophages. And if you targeted MARX in an in vitro system, you're actually able to reverse some of this. So identifying a potential novel target for these patients who have relatively few options available to them. So in thinking about obesity and dysregulated cell metabolism, this slide here is a relatively complex, and it's a little bit smaller than I was hoping. So it's highlighting some of the signaling pathways that are involved in regulating cell metabolism within cancer cells. And you may or may not recognize some of the very commonly studied proteins in these pathways. So PI3 kinase, which is encoded by the PIK3CA gene, as well as LKB1, which is encoded by STK11, P53 encoded by TP53. All of these proteins are important for regulating cell metabolism. And with the advent of our better understanding of how shifts in cellular metabolism affect the progression of disease, we've become very much interested in understanding how we might be able to target this. And it becomes especially important if we're thinking about how obesity influences the actions of these signaling pathways. So we don't often think about PIK3CA mutations being more sensitive to the effects of insulin, but they are. So in those individuals, hyperinsulinemia, hyperglycemia, such as what we see with diabetes, will further stimulate the actions of this mutated protein or this mutated gene. So I think it's important to think about, how these mutations interact with the environment, especially in the context of metabolic health. One study that was published I think just at the beginning of this year, actually, out of Zeynep Madak-Erdogan's lab, actually looked at the question of whether we can leverage our understanding of tumor metabolism to better treat disease. And we know that breast cancers that have mutations in the estrogen receptor that become resistant to fulvestrant actually utilize glucose at a much greater level than the endocrine therapy sensitive cells. What they did here is they leveraged the use of a ketogenic diet, which influences the amount of glucose that's in circulation, to be able to better target these tumors, especially in terms of liver metastases, in response to fulvestrant. And the data are quite compelling in the sense that, we see almost complete elimination of tumor formation in the liver. I don't know if I have, in the livers with a ketogenic diet. And this is really emphasized when we're comparing to the effects of fulvestrant. So I wanted to take a step back and also think about, those different demographics that may be affected by obesity differently. In this case, this was a study that was done out of Alabama, where they performed a retrospective cohort analysis of over 1,000 patients, breast cancer patients that had been seen over a 5-year period, and looked at the impact of race and obesity on the development of early onset breast cancer, so breast cancers that had occurred before the age of 45. And despite their population being a more than 2-to-1 white population relative to Black women, the majority of women who developed early onset disease were actually Black women with obesity. And I think this really highlights that there's a need for us to better understand how ancestry and biological differences may contribute to interactions with factors like obesity. These women also had a significantly higher risk of luminal A, as well as triple-negative breast cancer compared to their white counterparts. Work that came out of our lab started asking this question with regards to BRCA1 and BRCA2 mutation carriers. This is another population that hasn't been very well studied in the context of the impact of obesity and metabolic health. We now have an appreciation for the detrimental effects of poor metabolic health in this population, and our studies really aim to understand what molecular or mechanistic changes occurred within the breast tissue to account for potential increases in risk. In this study, we were able to access normal breast tissue from BRCA1 and BRCA2 mutation carriers, and This is just an H&E of the normal breast, and by using gamma H2AX staining, which is a marker of DNA damage, we saw a positive association between DNA damage and the body mass index of women. What was interesting is that the association was even strongest when we looked at fasting levels of insulin or HOMA2IR scores, suggesting that their metabolic health was actually a stronger driver of this damage. Interestingly, we also saw an inverse association between the amount of damage and SHBG level, or sex hormone binding globulin, suggesting a potential role of estrogens in driving this process. So to study that, we also looked at the tissue, and here is immunofluorescence data. Nuclei of the breast glands are in blue, and within that, the estrogen receptor is in pink, with the DNA damage foci in green. And we see that in both BRCA1 and BRCA2 mutation carriers, the areas of DNA damage are enriched in cells that express the estrogen receptor. This is consistent with our in vitro data using patient organoids, so mammary glands isolated from breast tissue, where estradiol stimulates DNA damage, and this is reversible with fulvestrant. So, this is consistent with our understanding of reducing estrogens being protective for breast cancer, but provides that additional mechanistic insight. We also know that aromatase and estrogen production are elevated in the breast tissue of women. We know that breast tumor-derived factors will stimulate aromatase in the breast, but with obesity, we also see elevated levels of aromatase relative to women of a healthy weight. So we have a number of factors that are changing within the breast that can account for an increased risk of cancer. Based on these studies, we are able to go back to our metabolic pathways and start trying to understand whether metabolic pathways may also be dysregulated in the tumor microenvironment, so outside of that cancer cell. And what we found was that indeed, with obesity, a lot of factors that we often study, like leptin and prostaglandin E2, are able to dysregulate these metabolic pathways, leading to an increase in estrogen production. What's really exciting here is that if we activate this protein called AMP kinase, which is a central regulator of energy homeostasis, we can reverse these effects and actually prevent the expression of the aromatase gene and reduce estrogen production. And it turns out that we have agonists available to us, and one of the ones that you're probably familiar with is metformin, which is a commonly used anti-diabetic drug. In fact, in our studies, in this case in breast tissue from BRCA1 and 2 mutation carriers, metformin was able to cause a dose-dependent decrease in estrogen production within these tissues, and that was associated with a significant reduction in the amount of DNA damage in the breast glands. Now, whether or not we're amenable to start studying the effects of metformin in this population, I don't know, but it really opens the door for us to start thinking about additional targets within these signaling pathways that may be effective for risk reduction in high-risk populations. We also performed studies in mice, and we were able to recapitulate the effects we were seeing. With a diet high in saturated fats, we also see more DNA damage in the glands of BRCA1 heterozygous knockout mice. This is associated with higher breast cancer or mammary cancer penetrance and decreased latency. So when we think about the role of obesity in driving response to treatment, data are somewhat mixed, and I think it's important to consider that there may be more to this story than looking at responses more globally. Again, we should be thinking about how various subtypes of cancers may be influenced differently by obesity, especially in terms of response to treatment. In looking at women with early stage disease, women with non-metastatic breast cancer with obesity tend to require chemotherapy more often than patients without obesity. In this particular study that was presented at ASCO last year, it wasn't clear whether this was due to the staging of disease, but what was clear was that this effect was independent of histological subtypes. So it wasn't that one subtype was more resistant to therapy than another in the context of obesity. In this study that was presented at the San Antonio meeting, which is really a follow-up of the Early Breast Cancer Trialist Collaborative Group study from 2014, but now with many more patients available, or data from patients available. This study really aimed to look at whether the data they had generated previously was consistent in this larger cohort, but also looking at first distant recurrence or impacts on first distance recurrence. So what was found, and I think what was striking in looking at these data, were just the finding that the prevalence of obesity had increased from 19% in the early 80s to 27% in the 2010s, which is pretty dramatic and speaking to the further prevalence and increases in rates of obesity, not only within the US, but internationally. What was found was that the overall relative risk of first distant recurrence was 1.06 for every 5 kilogram per meter square increase in BMI, which might seem like a large change in BMI, but considering the range of BMIs that women have that are seen in our clinics, I think this is quite important. And when we compare the relative risk of women with obesity versus those without, the risk increases to 1.17. We know that this relationship is linear, and we also know that this is independent of tumor characteristics once again. So we're kind of moving away from this idea that obesity is only associated with the risk of hormone receptor positive cancer after menopause. In this study, which was also presented at the San Antonio meeting, they started looking at the impact of obesity on chemotherapy-related outcomes, including toxicities associated with chemotherapy. And I think this is quite important, especially in light of current ASCO guidelines suggesting that full dosing and weight-related dosing should be provided independent of BMI. And that dose escalation should be tackled in the same way as what we see for women without obesity. There was one statement at the end of those guidelines suggesting that we need to better understand what the role of sarcopenia is in mediating toxicities, and this study starts addressing that in some way. That being said, it still shows that obesity is associated with higher chemotherapy toxicity, and that this risk is even greater in patients with sarcopenia. Now, this is an early stage disease. I'll show you data next related to therapeutic effects on toxicity in later stage disease, and maybe this is where the difference becomes clearer as we start understanding, where chemotherapy may be toxic and less so. So in this study, which is one of the first studies looking at the impact of obesity on the safety and efficacy of ribociclib in patients with hormone receptor positive and HER2 negative advanced breast cancer. What was interesting to see was that progression-free survival was indeed longer with ribociclib, but this was independent of BMI. So there was no added benefit of a healthy weight in this population. And I guess one area for conversation comes around, patients not necessarily needing subsequent chemotherapy when they had obesity relative to not having obesity. So this is suggesting, in fact, that having a higher BMI might be beneficial for these patients. But I wonder whether we're kind of going back to that space where we first started doing studies around obesity that were suggesting that having a healthy weight or a lower body mass index was associated with worse outcomes. And it turned out that a lot of those data were driven by individuals with advanced disease who had lost weight as a consequence of having very aggressive disease. So I'll be curious to see how these authors interpret those potentially protective effects of obesity in this population. So we're going to move slightly towards, our interventions, and we have a limited amount of time, so I'll skip through these relatively quickly, but it'll come as no surprise to you that, appreciating that there is a role for obesity in driving many of these endpoints, we want to be able to intervene in our patient populations to be able to decrease risk, to improve outcomes. So this was presented at San Antonio as well. It's a follow-up to, or it's an analysis of the Be Well study, which is a weight loss intervention study that's done mainly through telephone-based health coaching that focuses on caloric restriction and increased exercise. It's been very effective at reducing weight in women, and this analysis is really showing that patients in the weight loss intervention arm tended to experience significant reductions in all of the metabolic and inflammatory biomarkers that they were looking at, including leptin, C-reactive protein, and insulin. And all of these factors have been shown to be associated with recurrence and disease progression. So the fact that we're able to reduce these biomarkers is encouraging for us to think about ways of being able to reduce risk. Other studies in the exercise space that have come out recently, this paper was published from Lee Jones's group looking at the impact of exercise or physical activity on the risk of distant recurrence-free or on distant recurrence-free interval. They did this across over 10,000 patients from 26 centers, and what they found was that increasing exercise by at least 5 MET hours per week was associated with an inverse linear reduction in distant recurrence-free interval events. But this was true only up until 25 MET hours per week, at which point there was no additional benefit. So really showing a dose-responsive effect and also an upper limit of what we should be expecting people to do to be able to achieve results. In this case, there was an impact that was greater in hormone receptor negative cancers and also in premenopausal populations. In this next study, which is a follow-up from an exercise intervention, they were looking at the effects of prescribed exercise on a treadmill on the outcomes related to chemotherapy, in particular tolerance to chemotherapy and being able to increase the dosing that was appropriate. So what they found was that in patients who received anthracyclines, 77% had 100% chemotherapy RDI in the exercise therapy group versus 57% in the usual care group. And that really, speaks to being able to limit some of the effects of chemotherapy-induced toxicity in this population. So it's difficult to talk about obesity without talking about the new anti-obesity medications, of which there are many. Semaglutide is one that is a GLP-1 receptor agonist, and tirzepatide is a dual agonist of both the GLP-1 and GIP receptors. They act through many mechanisms. They'll act on the brain to regulate appetite, but they'll also act on the gut, in particular to limit gastric emptying, to reduce motility. And what this does is that it causes individuals to feel full and to lose weight. Studies of tirzepatide in particular have been especially effective in achieving weight loss goals in patients in general. And these go beyond what we normally target in a risk reduction approach for cancer, where it's estimated that a targeting of 10% body weight loss should be sufficient to reduce the risk of breast cancers. In this preclinical study out of Stephen Hersting's lab, they tested the effects of tirzepatide relative to control and caloric restriction. The data up here really show the reductions in weight of tirzepatide in red and caloric restriction in blue. What was interesting was that the effects on tumor mass were not able to reach what we were seeing with caloric restriction, but this might be a dosing issue. They certainly were able to reverse any diet-induced obesity effects that we're seeing. And I'll end on this slide, basically highlighting, the amount of interest there has been in this area, and this is just over the last year. There were 3 studies. One is proposing a study in individuals with residual disease. The second is looking at a retrospective analysis of breast cancer patients who have been on GLP-1 receptor agonists, and I'll just note that there are differences in weight loss profiles in individuals that are on endocrine therapy versus other types, and that's really important given that endocrine therapy is associated with weight gain. The last one is almost a caution. These are not peer-reviewed published papers, but the last one suggests that it may actually interfere with some of the effects of chemotherapeutics. And the last 3 here are the registered clinical trials, including the one that's led out of our institution by Carol Fabian. And I'll end there. Thank you.